So what is our definition? And usually as physicians now, we're starting to use the body mass index. Now, it doesn't work for everybody. People who are very muscular and tall, this is not as accurate. People who are very thin and small, it's not as accurate. But for the bell curve of people, it works pretty well. And overweight's a body mass index of 25.1 or greater to 29, and obesity is greater than 30. And so I gave you the charts there to kind of help calculate your body mass index. Because when we talk about surgeries, it's important to know about your body mass index to see if you qualify in that regard. So basically now in the United States, 2/3 of people are either overweight or obese. And what this brings is more complications associated with that weight gain. Diabetes, high blood pressure, high cholesterol, heart disease, stroke, sleep apnea, which we'll mention later, and lack of oxygen when you sleep at night. Just decreased ability to get up and move and go to work. Emotional and stress and depression factors all can play a role in this. So it's an important issue to address. And I think as physicians in the past, we haven't addressed it as much as we should have, or got as aggressive. Maybe we just didn't have the time, but it's become much more of an issue now. The metabolic syndrome is something that you may hear about. And really all it is a grouping of risk factors that somebody may come in with that puts them at substantial higher risk for an event of a stroke or heart attack. So we get very aggressive with these. Every one of these can be improved with weight loss. Even without medication, just bringing down weight will bring triglycerides in line most of the time, can raise the good cholesterol, the HDL, can improve blood pressure, and improve blood sugar. So again, it's really the weight that makes this all worse. So the most common cause is really an excess of calories, and it's about 3,500 calories to form a pound, and it takes 3,500 calories to burn to lose a pound of fat. And people store fat differently, but on average, this works out. Your genes will play a role, how much exercise you do. That has to do with energy out and how much energy you put in, how much food you're taking in. So it really is about the calories. There's been all kinds of stuff over the media the last couple of years that this diet is better than that diet because it's excluding a certain group, or this is just a low-carb diet and it's better than the high-carb diets. That's really not true. In the end, if you take them calorie per calorie, they're about equal. So basically, it's to find one that you like and can stick to. So I get this question all the time. How do I increase my metabolism? Well, exercise does help. Exercise helps preserve lean muscle mass. Muscle burns calories. So I often ask my patients, after they start moving more, I ask them to start doing some light weights to help preserve their muscle mass during their weight loss. And this NEAT activity stands for non-exercise activity. T stands for thermogenesis, or burning of calories. And that is just as important. That is just staying off the couch and moving. If you're on the phone, you pace back and forth. That's non-exercise activity, but it's burning calories. You do your own housework. You do your own yard work. Just moving helps. And there are studies now that show that people who just stay off the couch and move around their house can burn as many calories as a person who went and ran on a treadmill for 30 or 45 minutes. So what's the best diet? The one you can stick to the longest. That's the best diet. So it varies. Some people don't like certain foods, and they're not going to stick to a diet that incorporates a lot of the foods they don't like. So I've, in my research, found that there's very little evidence to support one diet over another. So I give patients the range to choose from. I say, find food groups that you like. Try to incorporate 5 servings of fruits or vegetables a day, or meal replacements, which we'll talk about later, which are shakes, power bars, and entrees that are low calorie that you can buy. Slim Fast would be an example. The HMR program I'm going to talk about as an example. But it is all about the calories in the end and how you burn that and how much activity you're able to do to counteract some of the excess calorie intake. So there are different types of diets, and very, very, very low calorie diets I call starvation diets. Below 400, this is 0 to 200. But these diets can cause a lot of fluid loss at first, maybe a week or so. After that, the weight loss generally slows down or stops. And they start metabolizing muscle mass, which is going to be counterproductive for later weight loss. And I just have not found it to be very helpful for the long term. Very low calorie diets, I usually don't recommend if they're below 800 calories. I generally recommend at least 800 calories a day. And 800 calories a day needs to be medically supervised because people can get vitamin deficiencies if they're not eating enough of the foods containing the vitamins on these low-calorie diets. And then these are things that people can do at home. I usually like to supervise people if they're less than 1,200 calories a day. Depends on their medical problems. They're totally healthy, 1,200 calorie a day is fine, but a lot of my patients have high blood pressure, diabetes, and if they're getting down to 1,200 calories or around 1,000, I usually like to supervise that myself. But if you just cut the calories over what if you're taking in less calories than you're burning, you're going to lose weight. So if you cut your calorie intake by 500 calories a day over your maintenance number of calories, and I'll talk a little bit about what a maintenance calorie is, but if you cut it by 500 calories, you'll lose a pound a week. You cut that by 1,000 calories a day, and you'll lose 2 pounds a week. That sounds simple, but your body perceives that drop. If you cut 500 calories, you will have an increase in hunger. You drop 1,000, you'll have an increase in hunger. That's why I like meal replacements to substitute in place for meals, because the shakes particularly are very filling. So you've already substituted a meal and only had maybe 150 or 200 calories, and then you don't have to worry about eating till the next meal. And we'll talk about those. So people who find the Atkins diet works, it often works for them because, number one, they like the foods, but proteins and fats tends to satisfy people more. So it's not necessarily the content of the food they're eating, but it seems to help some people feel less hungry, so by the end of the day, they've eaten less calories. People ask me, how many carbs should I eat a day? It doesn't matter as long as the calories in the end march out. Others don't like all of that fat or protein because it makes their stomach upset or they get constipated. Well, they can do a low-fat diet. But some people who are on low-fat diets or high-starchy diets, the starch, the sugar, stimulates appetite. It stimulates insulin release from the pancreas. That tells the brain often that it's hungry and wants to eat more, and can lead to excessive calorie consumption in some people. So you've got to find what works for you. That's often I ask people. They know what works for them. What works best for you? What have you stayed on in the past? What have you done in the past? And we try to build on that. If you take 12 and multiply it by your body weight in pounds, that gets you close to about how many calories it takes to maintain your weight. So 12 times whatever you weigh in pounds, and that gets you close. Then you just cut that. So without exercise, if you cut it 500 calories a day, you can drop a pound a week. If you drop it 1,000 calories a day, you can drop 2 pounds a week. You add exercise, you can lose more weight than that because the exercise is burning calories. Exercise by itself has never been shown to cause substantial weight loss without a diet also followed. And the reason is the exercise drives appetite. Excessive calories. It's easy to take in 400 calories extra, and it's harder to get on the treadmill and run for 45 minutes. So that's why exercise itself does not cause weight loss. But it's a great tool to use with these diets. It preserves lean muscle mass. It helps burn calories in the end. Our very low-calorie diets, and again, I start this at about 800 calories a day. What we're seeing in our program is about 3 to 5 pounds a week weight loss, but we have people who lose 7 pounds a week, depending on how much exercise they add to these meal replacements. And we are telling them to eat. We're not telling them to skip meals or sacrifice. We're saying eat, fill up, be full. We want to stop hunger. We give you 3 shakes a day that are low calorie, very filling, chocolate, vanilla, different flavors. Then we have you eat 2 entrees a day, and we have 11 different entrees to choose from, and I'll show you some of those later. And with this, you get to about 800 calories a day. This is the minimum we want you to eat. If you're hungry, we have people eat more. If they eat more, they often maybe get up to 1,200 calories a day, but maybe their maintenance calories were 3,000 to 3,500 calories a day. It's still a huge calorie deficit. They're still going to lose weight, but they're not hungry, because appetite is the #1 reason people fail diets. Starving, feeling hungry all the time is not a way to live. And that also involves, with our diet, behavior change and a support system, because staying on a diet long term is greatly enhanced, and success is enhanced if you have a support system involved, and you're checking in on them and you're weighing them each week, and they have some accountability and they have a support system. We have at our program weekly meetings that help, and we have a couple times so that you can find one that fits your schedule. And we encourage people all along the way. We keep them in maintenance after their initial weight loss. 13 weeks is our first program. If they want to go longer, they can certainly go longer. And then we put them into a maintenance program for up to 2 years, because we're working on changing that behavior. We're changing their perception of food, their relationship to food. For instance, this is one of our patients who has lost 100 pounds. Sugar was high in the 300s, now is down to what's considered very well-controlled diabetes, off of medication. Cholesterol was high, now it's normal. This is not unusual. It's unusual for 13 weeks. This was over a period of time. In 13 weeks, again, it's usually about 5 pounds a week weight loss. But often our patients have had success. They want to stay in. And after a year, year and a half, they can lose up 100, 150 pounds. We've seen that. I'm seeing it on a weekly basis without surgery. Another thing I love doing is when I look at their long medical list or medicine list, when they come to see me, I love shortening that list. We take them off a few of their medicines right away. Some of the high-dose insulins will cut down or remove. Some of their diabetes medications we have to stop the first day. Some blood pressure medicine stop the first day. And then by the end of the program, they may be off everything. And I just love explaining to them that it's like turning back the clock. They've been going this way for so long and having this medicine, this one added, all of which have some side effects, and now we're turning that back. We're reversing the process. And we give them the support to keep it going. We don't just say, thanks for coming to see us for 13 weeks, good luck. You have a system in place. And this is for men and women together. The average weight loss is about 44 pounds in our 12, 13-week program. So in the end, I find if patients lose weight rapidly on a program like this, that encourages them to stay in it. Who stays in a diet when you lose only a half a pound a week? Almost nobody. But in a program like this, they get rapid results, and then we're changing their behavior and their perception of food so that they can keep those results off and change their life long term. We're tracking their exercise too each week. And we have even a program we can get them in with an exercise expert to show them how to exercise. A lot of them have never exercised and don't even know how to do it properly. And that's the Lake Weight Solutions program that I've passed around. 765 Lose is our number. And this is an example of the products that come. Again, that's a lot of food. You're eating this every day. Now, when people go to maintenance, they don't stay on all of this all the time. They'll move to 2 meals or 1 meal a day to substitute, depending on how much weight that they want to lose or how they're maintaining their weight. But when they go home, we usually say eat 2 meals a day, so a shake for breakfast, an entree for lunch, and then they can have a sensible dinner, something that we taught them along the way what they should have. And we teach them portion control also. And my daughter made this presentation, so she made her last slide. All right, I'm open for questions. Yes? Yes. Yes. Mm-hmm. Yeah, and this is only one meal replacement approach. What we do, we have an at-home program too that is not supervised, but we'll give patients these products and send them, say, well, all right, take this entree with you on the trip, or take the shake mix and you just eat that for breakfast or eat that for lunch, and that's how we do it. Generally, the airlines are letting people carry these on board, and even out of the country, we had one of our patients took them all the way to France and did well, but Canada, no, for some reason. But yes, you can take it on the road. They take just a minute to microwave, or they can sit on the dashboard and heat up. So it's easy to do. Yes. Well, on this program, when you do the most aggressive 800 calories, every meal is replaced by this program and the products in it. So 3 shakes, 2 entrees a day. So you're not eating out, you're not grocery shopping, and that's where the cost is often offset, because people will say, well, how much does it cost? And for the most aggressive, medically supervised part of the program, it probably is about $450 a month. That, if they go back and figure out everything that they spent on food or gone out to eat, we get pretty close to that, I think, for most people. So usually people break even. Now, they're cutting back on medication, so that saves them some money too. So I like to think that we save them money in the long run, and we keep them out of the hospital and keep them from having, various procedures. So that's about, you'd ask me about the cost. Oh, a good bit of it. But the thyroid is fairly easily to control now with medication. And it's important to get people to what we consider a normal thyroid level before they can lose weight efficiently. Yes. Not that they can't lose weight, but it's very difficult when a thyroid is not there. It's part of the natural way of keeping up your metabolism. Yeah, it's a good metabolism hormone. Too much is not good either. Too much can cause some weight loss, but it also can cause heart rhythm problems and strokes and high blood pressure, and the list goes on. Mm-hmm. Yeah, I would find on our first month people are losing between 15 to 25 pounds. And again, a lot of that has to do with how much they're incorporating in exercise, making sure they're strict with following the diet. And after that, it's probably about, another 12 pounds a month. Or upwards, because again, some of our men who start to feel better and start doing exercise, they can start losing 5 to 7 pounds a week. After somebody starts to get close to their ideal weight, it slows down. It's kind of like the bigger you are, the faster you fall, and the rate does slow down. It's not zero, but our patients who have been in it for over a year's time, they're still losing weight. They're losing, instead of losing maybe 5 to 7, maybe they're only losing 2.5 pounds a week because they have less to lose at that point. And when you're losing weight, your metabolism still goes down. Think about it. If you have 50 pounds of fat that you're hauling around every day, or 100 pounds, that burns calories. That requires more muscle mass to do that. Well, you lose that fat, you're going to lose some muscle tone, so the metabolism goes down. And that's why if you do the figures on that 12 times your body weight, you'll see somebody 12 times 250 can take in more calories to maintain their weight as opposed to 12 times 150. Big difference there. And that's why it slows down too, because if they're on 1,200 calories a day and as their weight, say, comes down to 170, then the calorie deficit's not as much. When they were 270, it was a much bigger calorie deficit. That's why it slows down, not because it's less effective. Yes?
I have a question about body mass index.
Yes.
I've always wondered this. I mean, I'm in the extremely obese line up here. I'm 5'8".
Mm-hmm.
And to get down in what is called healthy is 158.
Oh, yeah. Isn't that crazy?
I haven't been that way since middle school.
It is interesting. I used to think that we could never get anybody back to their high school weight. I'd say, well, don't think about high school. Where were you at the end of college right before you got married? But the truth is, yes, on a program like this, we can get them back down to their high school weight. But they don't have to get to their high school weight to be healthy. 10% body weight. No, let's even say 5% body weight. We start to see improvements in blood pressure. 5% body weight. That's it. 5% body weight starts to make positive impacts on your health. You lose 10%, sugars are much better controlled in diabetics, blood pressure much better controlled, cholesterol's already dropped 20%. So I say, listen, let's try to get you at least 10%. Let's get you focused on 10%, because if you start thinking, I got to lose 150 pounds, some people just can't wrap their arms around that. 5%, 10% body weight. Once they get to 10%, they're like, oh, gosh, I want to go more. Okay, we'll shoot for the next 5%. That's how I do it. And then we let them dial in where they want to be, because often they feel a lot healthier with 10 or 15% off. It's not unusual that we get 20 or even 25% total body weight loss off these people. I had a guy who's already lost, in 3 months, he's already down 25% body weight. I mean, he started in the upper 300s, and now he's down into the upper 200s and on his 4th month. So but he said, I want to lose 50 pounds. I said, all right, that's great. 50 pounds, that's over 10% body weight loss. Let's shoot for that. And then all of a sudden, he was past that and thought, oh my gosh, this is too easy. How is this? So, but it does take discipline. We're having people just eat this food and not to snack on other things. And we're having them come to our meetings so we can coach them through it and then go into the maintenance group and coach them through that. And by the end of that 2 years, when they've gone through maintenance, the chances they're going to maintain the weight are much higher at that point. Well, I've used up about all of my time. Can I take one more question? Yes. They don't cover the meals because it's food. At this point, they don't. What they will cover is for if people are on a very low-calorie diet and they're seeing me, then they can turn that $20 in, I think, is the fee for that. And then that visit's every 2 to 4 weeks, depending on the program. But they can turn that back into their insurance company and be reimbursed for it often. So the food's not reimbursed. The meetings aren't reimbursed per se. But although people who have a health savings account, if they can take, they've already set that up and that's kind of tax-free savings, then they are able to put some of this back in there as far as taking the bills that they're getting through the program and using it through the medical spending account. As long as their physician said they need to do the program. All right. Thank you very much for your attention, and I'll be around later.
Nicely done, Brad. All right. Well, good morning, everyone. My name is Kenneth Kleinpeter. I certainly tip my hat to those who are attempting to be here to look for ways to improve health. This is one of the most dramatic ways that I've been around in order to do that. And one of the things to say is this is not simply a way to lose weight. The key point here is that we're trying to make one healthier with this maneuver, and it's sort of a nice side effect as a way to look at it in terms of the weight loss. Things like diabetes, high blood pressure, high cholesterol, those things can be dramatically improved upon. Like Dr. Meek said, the point of all this is to try to get people off those medications if they can and to improve longevity and lifespan. We'll talk about a few key points here today. One would be, what is the definition of morbid obesity? You hear that term thrown around. Certainly obesity has become much more sort of known about and much more common. A lot of popular televisions about that revolve solely around surgery for weight loss. It's because it's become such a common problem. We'll talk about the 3 surgical options that we as a group, the surgeons group of Baton Rouge, offers, and discuss candidate criteria, because this isn't for everyone. It's a dramatic thing to do. There is some risk related to a surgical weight loss operation, and we'll talk about those things specifically as well. So morbid obesity, the specific definition of that relates to BMI. And so if at some point there's a normal BMI, then there's overweight, then there's obesity, and then there's morbid obesity, and that triggers at a point of a BMI of greater than 40. Consequences of morbid obesity left unchecked over the course of a lifetime include increased risk of other serious medical conditions like those we talked about, diabetes, high blood pressure, which conspire to increase their risk and early risk of coronary artery disease and coronary death. This is sort of a laundry list of all the potential issues that can come about simply from morbid obesity. Diabetes and hypertension and high cholesterol, the top 3, all increase the chance of heart disease. And then the others, including many others not on this list, lung disease, blood clot risk, both DVT, clots and blood clots in the lower extremities, and pulmonary embolus, blood clot that can travel to the lung. Arthritis is a key one, because a lot of times people say, well, if you exercise more, you can lose weight. Well, it's very difficult to do that if your hips and knees have degenerated to a point where you cannot exercise effectively to lose weight. And so weight loss surgery or weight loss can put you in a better position to improve those habits and then continue on with weight loss. depression, urinary incontinence, all these other things that can be related to obesity can be improved upon dramatically. So the 3 surgical options that we offer, and the most common you'll find if you look across the nation, are the gastric bypass, the adjustable gastric band, and the sleeve gastrectomy, which is a little bit newer on its own as a technique. It used to be, and still is, combined with a second, much more dramatic operation, but it was found to be effective on its own in terms of pure weight loss and comorbidity resolution. And as it becomes more and more commonly done, and more data becomes available regarding it, it's becoming evident that it's an effective operation. So why all of these have become much more common now is because traditionally the bypass was done decades ago via an open incision. That, if you take someone who already has difficulty moving around, difficulty with breathing and whatnot, and if you put an incision there, it makes everything else more difficult. And those patients typically had a difficult time getting out of bed and had a much longer recovery and had a higher chance of developing deep venous thrombosis, blood clots that are potentially a fatal complication. Pneumonias, all those things made it much more risky to go through the surgery. Now that we can do this with smaller incisions and scopes and cameras, dramatically decreases that potential chance, and those people are out of bed much sooner. In fact, the day of surgery, we want them up and about and walking, going to the bathroom. So those risks are decreased dramatically doing this laparoscopically, and that's one of the major factors that has made this much more common. So to talk specifically more about the 3 operations, the bypass is probably, if you look across the nation, the most commonly done. It has been performed for the longest and has changed in subtle ways over the course of time, but again, the most dramatic has been that it's become a laparoscopic procedure. These operations work in 2 and sometimes 3 fundamental ways depending on how you look at it. One is they're restrictive. They decrease the size of the stomach and decrease the amount of food one can take in, calories that one can take in at any one point in time. And so that's one way to affect weight loss. The second way is a malabsorption or a malabsorptive way that it performs, and that specifically to say that this area of the stomach and all of this small intestine does not see food content necessarily in the normal course, whereby you swallow something that goes through the esophagus, into the pouch, and then down through the intestine here. None of this area sees food and is not effective for absorption anymore. Now, your digestive juices do meet the food here at this connection, and absorption can occur downstream. So it works in 2 ways. One, to restrict how much you can take, and then to decrease your ability to absorb the little that you do take in. And so in that way, it's the most effective in terms of pure weight loss and comorbidity resolution. It does reduce the size of the stomach per se, but the stomach and the intestine remain in the body, and we'll talk about why that's important in a little bit. And it is the most effective of the 3 in terms of average weight loss if you look at it over time historically in patients. Some potential risks of the bypass. It is unique of the 3 operations in that you do sort of take apart and reroute the intestinal tract. And so each of these points is a potential point of leakage. And so that's a major concern around the time of surgery. And we're very cautious to look for those things and act upon them aggressively if we suspect that may be happening. Herniation and obstruction is a lifelong issue potentially after surgery, whereby the intestine can get trapped within one of these reconnections. And so that's a significant problem after surgery in bypass patients. And those people typically would require an operation down the road if that happened. Stricture and scarring is a situation related to this connection specifically. It's called a gastrojejunostomy. It can become tight as it heals and generally can be reversed with an endoscopic procedure and ballooning and a dilatation to open that back up. Ulcers can occur along here at the site of anastomosis as well as anywhere in the stomach, just as anyone else who had gastric ulcers. Dumping syndrome is an interesting feature of this. Some might look at it as a complication or a downside of it. Others might use it as a tool to help avoid certain foods. Specifically, dumping syndromes whereby one eats a high-calorie, high-sugar content type food. If it gets into the intestine before it's been digested by the stomach, which would be the normal pattern, then that high-calorie food, when it gets to the intestine, can cause an awful feeling, queasy feeling. Your heart can race, you get sweaty, and may have some nausea, potentially even vomit. That can be used as a way to detract or to avoid certain foods in the future, which can bring on weight loss. Things like ice cream, high sugar type foods. So people will use that to avoid those foods in the future and help maintain weight loss. One of the major long-term issues with gastric bypass is vitamin and mineral deficiencies, and these patients do need to be on lifelong supplementation. To sort of go to the opposite end of the spectrum in terms of pure weight loss and potential risk to the patient would be to speak on the band. Bands are adjustable now. There used to be a fixed band that you'd place at the stomach, at the top portion of the stomach near the GE junction, so that this stomach is still in place, but doesn't necessarily function as it did before, and it's a purely restrictive operation. It restricts how much you can take in at any one point in time because you're left with essentially this little gastric pouch here to function as the new stomach, so to speak. So it is a purely restrictive operation. There's no malabsorption with this operation, and it decreases the caloric intake and therefore affects weight loss. The anatomy remains intact. You do not divide or reconnect any portion of the intestine. There's no malabsorption here, and so the risk of vitamin and protein malnutrition, all those things along the way, are a little bit less. But we do recommend vitamin supplementation for patients. And it is adjustable, and it can be reversible. Certain situations might arise where the band may need to come out, and that can be done. Some of the other downsides of the band would include mostly to do with the fact that this is a foreign body, and it is intended to remain in the body for the rest of the patient's lifetime. One of the things that can occur is a gastric slip. This is the portion of the band that wraps around the top portion of the stomach. The stomach can slip through that portion of the band and occlude and sort of cause an obstruction. And the patient would know that because it might become more and more difficult to swallow things and potentially have some vomiting. And so that's a trigger for the surgeon to say, okay, let me look at this a couple different ways. And if it is a slip, that can be managed potentially by taking all the fluid out of it to loosen it, but may require a second operation to fix that problem. And erosion is probably the most dramatic of the complications potentially with the band. Thankfully, it's very rare, but it can be where the band itself actually erodes into the stomach, causes an ulcer, and that's generally an indication to remove that band at that point. Port site problems. The port is very important because that's actually what you access to increase the fluid content within the band to cause pressure on the stomach to then make it tighter and tighter to limit what you're able to take in. If the port site ever gets infected, that becomes an issue where the port might need to be removed and potentially might require the whole band to be removed. And so we're meticulous about sterile technique when we access this thing. And you'd like to get it accessed to a point as quickly as you can such that you won't have to access it anymore. Get it to a point where it gives just the right resistance, and then that be it. Now, there are probably times where you'd have to give a little extra over the course of time where a tiny, microscopic amount of water can sort of migrate through the band, but that's pretty minimal. The sleeve is potentially the best of both worlds here, but it is a young operation, and it's only been done recently on its own. It was traditionally done as a step one of a two-stage operation with a much more dramatic malabsorptive operation done as stage 2. A lot of people found that before they came to need stage 2, they had lost enough weight where they were happy and comorbidities had resolved. And they said, well, I don't want to do that. And so they stopped at the sleeve. And so others speculate that maybe this could be done as its own operation and has really taken off here lately. It is a restrictive operation in that you take the stomach and you divide it along this line to leave a sleeve of stomach, and this portion of the stomach actually comes out. And so some people, if they get bothered by that, it's because it's technically an irreversible operation whereby that portion of the stomach comes out and it's gone. That is an important point to make with this procedure because this area is called the fundus here. That's one of the densest sites of production of a protein called ghrelin in the body, and ghrelin is related to appetite. So as you approach a meal and as you become more and more hungry, it's known that the ghrelin levels get higher and higher. You eat, your appetite goes down, the ghrelin levels go down as well. And so there's some relationship between ghrelin and appetite. So if you can get that ghrelin level down, you can hopefully affect a good change on appetite, decrease appetite. And a lot of that is the battle behind weight loss is decreasing caloric intake related to appetite. And so it can be very beneficial along those lines. There are no foreign bodies here with the sleeve, so that's one benefit to those who might have a problem with the band being a foreign body. And in contrast to the bypass, you're not rerouting any intestine. There's no malabsorption here necessarily. Other points to make about the sleeve gastrectomy, the weight loss really tends to be closer to the bypass. Certainly in our practice, we've seen much more weight loss with the sleeve than we have with the band. almost on par with the bypass. The bypass still is the highest in terms of pure weight loss. The hormonal benefit is incredibly important with the sleeve and is much more striking than with the band and even with the bypass. You can convert this to a bypass if needed be, and it is technically easier to do the sleeve than it would be to do a bypass in the case that somebody's had multiple operations in the past and then would potentially have dense scar tissue. The nutritional risk is less with the sleeve and the band than it would be with the bypass, solely because of the malabsorptive issue related to the bypass. These are not malabsorptive operations. It cannot be reversed. That's one thing that bothers people if they're considering a sleeve related to the other two. And it is it's only been known, and some of the more recent papers have talked about 6-year data and looked at results along those lines, but no one can tell you what's going to happen in 20 years related to a sleeve. It's just not been around that long. And if you look at this sort of overall chart, it looks at the 3 operations, and if starting on the bypass side, it's potentially the greatest benefit in terms of weight loss, but it also comes at the expense of the greatest potential risk. And then on to the band, which is sort of a slower weight loss, but in some ways you look at that and that's potentially a more healthy way to lose weight, but just requires more patience. The bypass, it's technically reversible. You can reconnect those things. You do not take any of the intestine or stomach out. The sleeve actually is irreversible from the standpoint of that stomach coming out, and it stays gone, and it is gone. And the band is completely reversible. Those bands can be removed if needed be. The weight loss with the bypass and sleeve is going to be much quicker than with the band. And if you look at sort of historical averages, to make the numbers a little bit easier, let's say somebody weighs 250 pounds. They've got 100 pounds of excess body weight if their ideal body weight is 150 pounds. So if you look at that 100 pounds, you ask yourself, well, how much would each of these 3 surgeries help you lose? On average, the bypass will help you lose about 75 pounds of that 100 pounds. So it's about 75% of your excess body weight. The sleeve tends to be somewhere between 55 and 65%, depending on the study, of excess body weight loss. And then the band is somewhere a little lower, about 30 to 40%. But certainly each of these can have great success and have people lose well over 100 pounds. And other ones have failed for different reasons and don't affect much weight loss. In terms of candidate criteria, who would benefit from this? You have to be careful because you don't want to take someone who's right on the borderline and subject them to the risk of all this and not hope to help them lose a lot of weight and to improve comorbidities. So the BMI criteria is a strict one, greater than 40, and then greater than 35 with comorbidities, diabetes, high blood pressure, those things. Endocrine causes of obesity, things like hypothyroidism is one way that someone gains weight. If that's treated and you've got them to a euthyroid or normal thyroid state, then they can go on and proceed with bariatric surgery. The other key points to make, everyone gets a thorough medical evaluation, a thorough psychiatric evaluation pre-op to make sure that they can tolerate the changes that go on with this. We talked briefly about drugs and alcohol and addictive behaviors. You have to be real careful about that because if you take away a food addiction, then potentially there's something called addiction transfers, whereby they may revert back to an alcoholism or a drug problem that they may have had in the past. So that's one thing to be very careful with. Otherwise, the thing that's very important to say about weight loss surgery is it is a tool, just like any other diet, any other way to lose weight. One's got to be dedicated to this over the course of a lifetime and continue these good habits that come out after surgery such that one loses weight and then is able to keep it off over the course of a lifetime. It's very important that the initial weight loss happens mostly with diet change and the surgery itself. But then beyond that, it becomes important to increase things like exercise regimens and to be careful with eating habits over time because each of these 3 operations could potentially be defeated. And there are plenty of people who've lost a lot of weight and then gained some back. And so things like support groups that we offer all become incredibly important because you hate to see someone sort of fall off and then disappear from a program, gain weight back. Those are the people who need to be in the support group more strongly than anyone else, and sometimes they'll feel guilty and stay away. Well, that's not the case. We want everybody to be in and sort of benefit from that. And so support groups and nutritionist evaluation and help from nutritionists all become very important long term. So it's all very important here. Surgery is just one step in all this. Well, guys, I thank you for your attention. I certainly appreciate y'all being here. I'd be happy to answer any questions you might have. That's a great question. That's why you maintain. Let me back up to the picture of the anatomy. The question relates to what happens to the stomach, the pancreas, the bile ducts, all those things that are that continue to create liters of fluid that you don't think of on a day-to-day basis. That's why it's so important. That's why we reconnect downstream. All those juices are created, they flow downstream here, and then meet back up with the intestinal tract there. So that is all maintained to help with digestion. But it's initially bypassed, and all of this intestine is bypassed for absorption. So if you sort of look at textbook averages and things, most people have about 500 centimeters plus or minus of small intestine. You bypass about 100 to 120. Some people even do 150 centimeter bypasses, where this limb, this connection is somewhere between 100 to 150 centimeters, but you still have plenty of other small intestine help. So you're certainly not bypassing the entire small intestinal tract. Correct. Correct. So it is. It's important for someone to remain on supplementation. Absolutely.
I have a close friend that had a lap band for 28 months, and I asked the question the other day, is that now that she's learning to eat such small portions, will she ever have to band removed? And she came back and said no, because I guess the history shows that the people can return. Is this true? I mean, is this something? There's no, once you get it, it's very difficult. Even though you train yourself to eat small quantities, you still tend to be dependent on it.
It's a great question, and it's purely speculation on my point. But what you would hope that you do is by putting the band in place, you initiate new behaviors, and so that person would eat smaller quantities, and in a way that would become her new normal. And if you look at the portions that we eat in America, they're grossly oversized. I mean, there's just way too much food than you'd ever need. So honestly, a lot of the portions she eats are probably a little more along the lines of normal. Technically, if you just took, if she didn't even know that the band wasn't there and continued those behaviors, you'd hope that she wouldn't gain weight. So technically, you wouldn't need that band after a certain point if your behaviors remained the same. You might not need that band to continue that behavioral pattern and keep that weight loss where it was. So a lot of people get bothered in situations where you think that they might need their band out for different other reasons that might come along, slips, some sort of complication. A lot of people want to do everything they can to save that band, and in a way it becomes a security blanket. But technically, if you've changed your behavior and you can maintain all that, whether or not there's a band in place, you'd hope that you'd be able to keep that weight loss off. So that's a great question. That study is not done, obviously, but what would happen to somebody who had a band and another cohort that had a band, and at some point you took the band out of one group, would they all gain their weight back no matter what, or would some continue with that weight loss that they had initiated versus those who had the band in place? So that's a great question. There's not an answer to that question that I know of, but a lot of times if the band comes out for some reason, people will regain weight. But you'd hope that they could maintain those behaviors and keep the weight off. Good question.